Local anesthesia, middle superior alveolar block. The equipment needed for this procedure is as follows: personal protective equipment, syringe, 27-gauge short needle, gauze, anesthetic cartridge, topical antiseptic, optional, topical anesthetic, cotton tip applicator, and hemostat or cotton pliers. The middle superior alveolar, or MSA block, may be indicated for dental procedures in the maxillary premolars and mesiobuccal root of the maxillary first molar. To ensure complete anesthesia to the entire quadrant, most clinicians administer this block even though the middle superior alveolar nerve may not be present. For individuals in which the middle superior alveolar nerve is absent, in approximately 68% of the population, the area is innervated by both the posterior superior alveolar and anterior superior alveolar nerves. The MSA block anesthetizes the pulp of the maxillary first and second premolars and possibly the mesiobuccal root of the maxillary first molar and the associated periodontium and buccal soft tissue, including the buccal gingival tissue if the middle superior alveolar nerve is present. If palatal or lingual anesthesia of the soft tissue of these teeth is desired, a greater palatine block may also be necessary. The landmarks for this injection are the maxillary mucobuccal fold and the maxillary second premolar. The deposit location or target area for the MSA block is the middle superior alveolar nerve at the apex of the maxillary second premolar. The needle insertion point or injection site is the height of the mucobuccal fold at the apex of the maxillary second premolar. You will insert the needle into the mucobuccal fold until you locate its tip superior to the apex of the maxillary second premolar without resistance or bony contact. Load the local anesthetic syringe as demonstrated in the procedure, loading the metallic or plastic cartridge type syringe. Before injection, follow all steps as demonstrated in the procedure, basic injection technique. Assume the correct operator position for a right-handed clinician at 8 o'clock right side or 9 o'clock left side, or a left-handed clinician at 4 o'clock right side or 3 o'clock left side. Ask the supine patient to open his mouth and then retract the upper lip, pulling the tissue taut. You may use a piece of sterile gauze to help retract slippery tissue. Pull the upper lip more anteriorly to avoid having to go through any large frena. Palpate the zygomatic alveolar crest to ensure that you will not contact bone prematurely and determine the apex of the maxillary second premolar. Dry the penetration site and prepare the alveolar mucosal tissue with topical anesthetic in the vestibule at the height of the mucobuccal fold superior to the apex of the maxillary second premolar. Topical anesthetics are most effective for patient comfort when applied for 1 to 2 minutes. Dry the tissue to remove excess topical anesthesia. Using a 27-gauge short needle in the syringe in the dominant hand, orient the bevel of the needle away from the large window of the syringe to ensure that the bevel orientation is toward the bone. Establish a fulcrum that allows you the greatest stability of the syringe. Place the syringe parallel with the long axis of the tooth, with the large window facing you. Insert the needle at the height of the mucobuccal fold at the apex of the maxillary second premolar, parallel to the long axis of the tooth and approximately 5 millimeters or 1/4 of the depth of the short needle, or until the bevel is slightly superior to the apex of the tooth. You should not meet resistance or bony contact. If a large frenum is present, move the insertion point to a more posterior site. Aspirate by pulling the thumb ring back gently on 1 to 2 millimeters at the injection site to prevent the possibility of an intravascular injection. If a negative aspiration is achieved, slowly deposit approximately 0.9 to 1.2 milliliters of solution, or 1/2 to 2/3 of the cartridge, over approximately 60 to 90 seconds. If the tissue balloons, the injection is too rapid. Carefully withdraw the syringe and immediately recap the needle using the one-handed scoop method with a needle sheath prop or other recapping device. Rinse the patient's mouth and wait approximately 3 to 5 minutes until anesthesia takes effect before beginning treatment. Complications from this injection are minimal and include pain on injection from needle insertion against the periosteum, pain on injection from too rapid injection, ballooning of the tissue, hemorrhage at the site of injection, and inadequate anesthesia, which may occur if anesthesia is injected into an infected area.